How's that? All right, okay. I just wanted to say, for these talks, if you guys have any questions, link to me on LinkedIn. And if you have any questions, send me questions through LinkedIn. I'll do my best to answer them related to any of these topics. Okay, notice that I used electrocardiogram motif for this talk about depression because there's a lot of recognition now that depression and cardiovascular disease have a rather prominent nexus. So a little more Menninger stuff again. There's Charles Menninger in the middle, and that's Will on his left and Carl on his right. Menninger Clinic was, in the most recent year, ranked the third best psychiatric hospital in the country by US News and World Report. This is our campus, seen from above, and we have the Commons building here, which is our administrative building, and then we have 5 buildings. This is the adult division here, Hope Unit, and then Professionals Program, which is the program that I'm responsible for. This is our stabilization unit. Now, Menninger is an out-of-pocket hospital for the most part. Our average length of stay is about a month. And, most insurance companies will use acute criteria from McKesson, and so they'll only pay for like 3 days of it. So the stabilization unit right here, 5% of what we do has to be charity. So we do take some charity patients on the assessment unit. But for my patients who come on PIC, they'll easily spend about $60,000 during their stay. And then you have the emerging adult division here. This is the young adult Compass unit, and then the adolescent unit ATP. And then they're building an outpatient clinic here. And this is Main Street right here that takes you to the medical center a couple of miles away, the main campus. So this is what our campus looks like. It looks sort of like a community college. It's a very attractive facility. That's the unit that I'm responsible for. We're changing the name from Professionals in Crisis to just Professionals Program. And that's the Commons building entrance. So another picture. And then this is what the inside of our units look like. This is the gym. We have a gymnasium there. And this is the chapel. These are stained glass windows here now. But this is the Interfaith Chapel. We have, and this is what our rooms look like. And on PIC, we have private rooms on the professionals unit. Looks sort of like a hotel. So to say that Jill and I love living in Houston would be, as Brian Regan, the comedian, would say, the epitome of hyperbole. But it is, it is a fascinating city. It's the most diverse city in the country. It's roughly a third, it's like 40% Hispanic, about 26% European, about 23% African American, and then the rest is everything imaginable. We have a very large Nigerian community. Not far from where we live, there's a big African grocery store. There's a giant Hindu temple there. It's a really fascinating city. And World Series, okay. So we'll talk, and the Rockets are on top of the Western Division, I think, so we're going to go see them in a couple of weeks. Texans, we have professional rugby there now. We do not have a hockey team. Okay, so we're going to review the diagnostic criteria, differential diagnosis. We'll talk about available treatments, and then we'll talk about important considerations in the selection of an antidepressant. So I have a number of slides about the burden of depression. Some of these are classic slides, but the second leading cause of years lived with disability in the world is depression after cardiovascular disease. This is an article from 2014 in Circulation. One of the authors is a friend of mine, Lawson Wilson. He's in the Association of Medicine and Psychiatry. We've both been past presidents of that organization, and this is where, in Circulation, they noted that depression is a risk factor for poor prognosis in cardiovascular disease and acute coronary syndrome. So this is one of those classic sites. The first reference, one of the references is by Leonard Agede. Is he still in Charleston?
No, he's moved.
Oh, okay. He was a guy who was in Charleston when I was there, and he did an important study looking at diabetic outcomes in patients who are depressed. Their diabetic outcomes are worse if they suffer from depression. One of these articles is also by a guy named Wayne Caton, who died just a couple of years ago, and he was very important in looking at the psychiatric burden of general medical illness. And another one who is also famous for that is Jürgen Unitzer. I knew him when he didn't have the dots over the U. And him and Wayne Caton are both from Seattle. And they did a lot of work on the interface between primary care and psychiatry. So you can see 20% of post-MI patients get depressed, patients with chronic lung disease, diabetes. This is an interesting statistic. Men who suffer from depression are 3 times as likely to die from a stroke compared to non-depressed men. So you can see there's Caton again and Unitzer, 2 of the Seattle boys. And you can see that these are high service utilizers, patients who are depressed. That's a picture of Jürgen Unitzer. Again, he staked his career on what we call integrated care now, and I'd like to talk a little bit about integrated care before this talk is finished. So ADLs suffer in geriatric patients who get depressed, and then their quality of life is worse. It's really suffering, very subjective suffering that the patients have. And one of the most important reasons to diagnose and treat it in general medical and primary care settings is that there are very effective treatments. So this is an old slide that I still use because this slide, this website, this web page was published by the American College of Physicians at a time when a lot of internists really didn't buy into diagnosing and treating depression in primary care. And so the ACP was telling patients who visited that webpage, if you're depressed, see your internist. And then, one of the guidelines for the treatment of depression, the ACP has one of their guidelines is diagnosis and treatment of depression. Now this is an article, Clinical Guideline Part 1, May 2000. And I put a little red line here because what the author says is that major depression and dysthymia, so we'll talk about dysthymia a little bit later, are the two of the most common debilitating illnesses. The lead author says, depression is a clinical syndrome lasting at least 2 weeks during which the patient experiences either depressed mood or anhedonia, plus at least 5 of the following symptoms. So I read that back in 2000, and I went, wait a minute. That's not what the DSM says, And I was like, what? Why? So this is a total of 6 symptoms, isn't it? There's 2 major criteria, depressed mood and anhedonia, and then 7 minor criteria. And the DSM says you have to have 5. So this article says you have to have 6. And I thought, well, let me get back and look at the DSM. I gotta make sure, So, and in fact, it says 5 or more of the following symptoms have been present during the same 2-week period. Now this is from DSM-5. A change from previous level of functioning, depressed mood, anhedonia. So one of them, at least one of them has to be depressed mood or anhedonia. Those are the 2 major criteria. The other 7, feelings of guilt, helplessness, hopelessness, worthlessness, suicidality, or thoughts of death, change in energy level, change in sleep. Those are all the minor criteria, but you have to have at least one of the 2 major criteria. So I've never seen a retraction published on that, and so I didn't know if the ACP had different standards than the APA, but don't get confused. It has to be 5, not 6, okay? That's node 1. So like all psychiatric disorders, it has to be a disorder. So it has to cause clinically significant distress or impairment in social, occupational functioning, or some other area of their life. It's not due to a physiologic effects of a substance or other medical condition like hypothyroidism, for example. And it's not better explained by a different psychiatric disorder. Those disclaimers are present in virtually all psychiatric diagnoses in DSM. So these are the new modifiers with anxious distress. And this is a really important fact. So many patients who are depressed do not complain of depression, but they may complain of anxiety. If you have a patient who meets criteria for depression, and this happens not infrequently, they don't have depressed mood. So they don't think they're depressed, but they do have anhedonia. They do have inability to enjoy normally pleasurable activities. So they have low levels of serotonin, and so they get anxious, and they may even have panic attacks. So on my unit, professionals program, a lot of my patients, they're doctors, lawyers, I've had professional athletes, actors, they will complain primarily of anxiety, and they don't think they're depressed. So I got to convince them they're depressed, which is difficult to do. There is the melancholic features. Melancholic, this is the diagnosis that Hippocrates made 2,400 years ago. A state of aversion to food and insomnia. So Hippocrates said that these patients with melancholia have insomnia and decreased appetite. So we still call that melancholia. There's the atypical form, though, where they sleep all the time and they have increased appetite and weight gain. And then the mixed. If they have one each of those, they can be mixed, melancholic and atypical. They can have mood congruent psychotic features. One of the most interesting is nihilism. And I've seen a couple of cases of this, where the patient believes that they have died. We had a case at University of Virginia when I was a resident of a woman who had a cardiac arrest. She was resuscitated using a defibrillation and developed a major depressive episode with nihilism. So she believed that she had died, and she spent a lot of time apologizing about what she believed was the smell of decay that she was emitting, and then she had to get shocked again to get rid of that, or to improve that. So that was fascinating. So that's mood congruent nihilism. Mood incongruent would be like grandiosity. Catatonia is both a medical and psychiatric problem, and then peripartum onset and seasonal pattern. So differential diagnosis includes physiologic effects of a substance or other medical condition. What do you think is probably the most common substance that produces the depressive syndrome? Alcohol, absolutely. It creates a neurochemical environment in the brain that is basically identical to depression. Bipolar disorder, bipolar depressed, that's a trap that all of us step in once in a while, treating depression in a bipolar 1. ADHD, because they have some cognitive side effects, adjustment disorder with depressed mood, sadness, and dysthymia. So I still use this slide too, July 1st, 2007, the core curriculum internal medicine from the Graduate Education Committee said that the residents need to know how to treat depression. It's still really rare for medicine residents to rotate with me, though. It happens, though. So this is from the AHRQ. They recommend, the U.S. Preventive Service Task Force recommends that we screen for depression, so we all do it now pretty much in most systems that we work in. One of the articles that they used to make this recommendation was one that was first authored by someone that I co-authored a paper on PTSD with, Kathy Magruder. And the medicine used was Xanax. So the world is an interesting place. Okay, so risk factors. It runs in families. Women are more likely to get depressed than men. And this may be strictly a testosterone thing. I'll never forget a patient I had when I was when I was doing the medicine part of my training at University of Virginia. She had red cell aplasia, and she had been exposed to probably parvovirus B19. And she had a Polaroid of her kids with the red cheeks, and we treated her with testosterone, and she got a little obnoxious, frankly, you know? So, substance abuse, lack of social supports, medical comorbidity like cardiovascular disease, postpartum period, and the usual age of onset is less than 40 years old. So in the DSM-5, it mentions temperament can be a risk factor. They mention neuroticism, but here they're referring to a negative sort of outlook. Adverse childhood experiences. I put hashtag the role of psychotherapy there because these are part of the reason why psychotherapy is so important in the treatment of depression, in at least many cases. And so it runs in families. And then there are modifiers like having borderline personality disorder, substance use anxiety, and so forth. So one of the things that, this is an example, this is just meant to show all the different, so you have depressed mood and anhedonia. Those are the major criteria. Suicidal thoughts are thoughts of death. Change in sleep, either up or down. Low energy, difficulty with concentration, fatigue. Actually, this is the low energy. This is psychomotor agitation or retardation. Change in weight is more valuable than change in appetite. I had a patient in Charleston, kept telling me he had no appetite, and his wife was a nurse, you know? And so I kept saying, well, you know, she goes, I fix him this nice dinner, you know, and he won't eat any of it. And I looked at his weight, and it was actually increased slightly. And I said, well, so you can't eat anything? He goes, well, ice cream is about the only thing I eat. And I said, how much? And he goes, about 2 gallons a day. And I'm like, so change in appetite, change in weight is a little better. It's a sign, not a symptom. So feelings of guilt and worthlessness is also one of them. But I want to point out that in the gravitational pull toward empiricism, there are 2 signs and not symptoms. Change in weight is a sign, and psychomotor agitation or retardation is also a sign, not a symptom. We're not supposed to ask the patient. So when I'm doing an evaluation on a patient, I say no obvious disturbance of psychomotor activity or speech, because I don't know them. And now if I have a family member saying, yeah, this is not his spontaneous level of physical activity, he's normally more animated than this. So that has to be something that's objective or empirical. Okay, so suicidality is, we need to screen all patients who are depressed for suicidality. Prior attempts is an important thing to note. Expressing hopelessness. The elderly white male who lives alone, when I lived in Idaho, you know, that's a part of the world where the suicide rates are actually quite high, and you have a lot of these old white guys who live alone. Up in the mountains and stuff. So the elderly white male is the highest risk demographic for suicide. Family history, substance abuse, medical illness, and psychosis are all risk factors as well. Maybe if I stand over here. Okay, so anybody recognize that plant? That's Rauwolfia serpentina. And that is the plant that gave us one of our very first antihypertensives, reserpine. And reserpine, excuse me? Depression, exactly. 1 out of 6 patients who took reserpine developed depression, severe depression. It reduced blood pressure by reducing serotonin, norepinephrine, and dopamine. And as a matter of fact, although I don't believe this is any longer available in the United States, it was FDA approved for the treatment of psychosis because it depleted dopamine. I only used it once. I was not impressed. But anyway. But this unmasked the neurochemical substrate for the depressive syndrome. And there was another thing that did as well. Let me go back over here. The treatment of tuberculosis. So this is Irving Selikoff, who in 1951 published a paper about treating tuberculosis with iproniazid. And in that article, in that initial article about the successful treatment of tuberculosis with iproniazid, he said, and it really peps people up. This medicine really peps people up. And actually, if you look at the chemical structure of it, It's similar to isoniazid, but it's also similar to phenelzine, Nardil, a monoamine oxidase inhibitor antidepressant. And so that plus reserpine, and so it increased levels of serotonin, dopamine, norepinephrine. And this plus reserpine helped unmask the neurochemical substrate for the depressive syndrome. This is a guy named Jim Hujak. He used to say there are probably depressive phenotypes, that maybe there are depressive types that are primarily serotonin deficient, because we think that the depressive syndrome is a product of a deficit collectively or severally of the biogenic amines dopamine, norepinephrine, and serotonin. So wouldn't it be great if we could say, okay, we've got an anxious patient, this is an SSRI patient, or we've got a patient who has anhedonia, so they need Wellbutrin, I think this way sometimes, but we still don't have evidence for this. But it's an interesting thought. Are there depressive phenotypes that could guide our choice of antidepressant therapy? These are some of the most common antidepressants. And you can see that virtually all of them increase brain levels of serotonin. This is just my dead reckoning here based on my clinical experience and some reading. Notice that one thing that's really unique about Wellbutrin is it doesn't increase serotonin. For that reason, we use it sometimes cautiously in patients who are bipolar 1s who are depressed, although I've seen a few go manic on it. It's mostly thought that serotonin produces that outcome, but it's mostly noradrenergic and dopaminergic. Once in a great while, I'll put a patient on bupropion and they will complain of auditory hallucinations. Not very common, but it has happened. But since it doesn't increase brain levels of serotonin appreciably, it is not really good for the anxious patient, unless their anxiety is strictly a metaphenomenon to their depression, which is not uncommon. So some of the nuisance affinities, alpha blockade, obviously bad in tricyclics. Remeron has a little bit of alpha blockade. Histamine blockade is associated with sedation and weight gain. And then there's a bunch of other stuff like the corrected QT interval with tricyclics and with citalopram. Citalopram has an important drug interaction with some of the proton pump inhibitors, which could really increase the QTc potential of that medication. Bupropion, rare cases of hypertension, the potential seizure risk, primarily we think of that in patients who have seizure disorders or who have eating disorders. Nifazodone, which used to be marketed under the brand name Surzone, is no longer marketed that way because the company that made it withdrew it from the market because of very rare cases of fulminant hepatitis and hepatic failure. I think 1 in 500,000. It also has a really unfortunate interaction with some of the HMG-CoA reductase inhibitors, 40-fold increase in serum levels of Lipitor and Zocor. So you got to keep your mind on that. But I use Hippocrates to do that mid-interaction check thing. Okay, so treatments for depression include psychotherapies. There's a number of different types. CBT is the gold standard. There's more data on that one than other psychotherapies. Then there's the somatic therapies, as we call them. In psychiatry, medications, oral, topical, and parenteral, TMS, ECT, and as this article states from Holland in the Journal of Affective Disorders, a combination of psychotherapy and pharmacotherapy is more effective than either alone. So CBT, how many people here could refer someone for CBT if they needed to right away? Okay, so actually that's better than I usually see. Because not everyone has access to a cognitive behavioral therapist. If, there are therapists in Houston, now that's an oil town, but who charge $300 an hour or more. and so if they're going to be doing 10 sessions, you see, they're really into it for a big investment, And then, one of the things like when you're reading about psychotherapies in journals like the Annals of Internal Medicine, there's a sort of perspective you get like, and therapy has no adverse effects, like medications do, but it can. Up to 1/6 of male therapists get into sexual relationships with their patients, according to the Institute of Psychiatry. And sometimes people clash, up to 2% of female therapists. So there are potential bad outcomes of therapy as well. It's not free of problems, So there is no convention on naming first and second generation antidepressants, but I call the first generation antidepressants the tricyclics and the monoamine oxidase inhibitors because they were the first ones. So you have tertiary amines like amitriptyline. The terminal nitrogen has 3 carbons attached to it. It goes through the liver and is metabolized to nortriptyline, which is a secondary amine. So one of the carbons is cleaved off. Imipramine and desipramine have the same relationship. Loxapine and amoxapine also have the same relationship. Now, interestingly, loxapine is not an antidepressant, it's an antipsychotic, but it's a metabolized to an antidepressant. So those, you don't really see those used much anymore. But clomipramine is used almost exclusively for obsessive compulsive disorder. The tertiary amines have more side effects, more alpha blockade, more sedation, more QT interval prolongation. The monoamine oxidase inhibitors, of course, are complicated to use. These are the oral ones. And then what I call the second generation antidepressants are the SSRIs. Fluvoxamine, like clomipramine, is used almost exclusively for the treatment of obsessive compulsive disorder. And then you have the SNRIs and then the other antidepressants. So there's the skyline of Houston, a mighty city. Houston is the 4th largest city in the country, actually. It's supposedly going to surpass Chicago in about 10 years, I think, as the 3rd largest city in the country. So these are the SNRIs. There's Desvenlafaxine or Pristiq, Venlafaxine, duloxetine or Cymbalta, milnacipran, which is called Savella. I like the name of that, Savella. Joey Savella was over there. We saw Jersey Boys last night. And then levomilnacipran, which is Fetzima. And then these are the other antidepressants. So you have, this is a gorgeous Hindu temple in Houston. Absolutely beautiful. So you have, the others include Wellbutrin, Remeron, Nifazodone, Trazodone, Vilazodone or Viibryd, and then vortioxetine or Trintellix, formerly known as Brintellix. But the FDA made them change the name about 2 years ago because it sounded too much like an anticoagulant. So there were 2 meta-analyses published in the Annals. Now, this goes back a little ways, but they talked about the second generation antidepressants in terms of efficacy. And this was a 2-part. They reevaluated this a couple of years later, and I think this is the second version of it. And here's what they found comparing these medications. There was no significant difference between the SSRIs in terms of speed of response. Pooled results from 5 comparisons between sertraline and fluoxetine found a modest advantage for sertraline. That might be because all of sertraline's top 3 receptor affinities are therapeutic. Sertraline heavily, a little bit of norepinephrine, tiny bit of dopamine. And then a slight edge for venlafaxine relative to SSRIs, but some of those studies were industry sponsored. So I think that's true. I think Effexor or venlafaxine is a slightly better antidepressant than the SSRIs. Remeron worked faster than those 3 SSRIs. For that reason, when I was doing a lot of consults in Boise, Idaho on the palliative care patients, I used to use that one because I thought, well, if it works faster, these people have limited time. We want to reduce their suffering as quickly as we can. Effexor was more likely to cause nausea than SSRIs. Bupropion has basically no sexual side effects. So for weight gain and sexual side effects, this is really by far the best agent. And then Remeron, sertraline, and Paxil had more sexual side effects than other agents. That has not been my experience with Remeron. I don't think, only rarely do patients complain of sexual side effects on Remeron in my clinical experience. Mirtazapine does cause weight gain though, does stimulate appetite. Paxil stimulates appetite and can cause weight gain. Bupropion does not. Effexor can cause elevated blood pressure. About 13% of patients who take venlafaxine will get significant elevations in blood pressure, and that's dose related. So bupropion is associated with insomnia, so you don't give the second dose too late. I've had a number of patients tell me that they have trouble sleeping, and then I say, when are you taking your second dose of Wellbutrin? Bedtime, you know. So you got to get them to take it in the earlier mid-afternoon. And then Effexor causes dizziness. Now Effexor, actually, the most dizziness is when you stop it. Anybody try to taper a patient off of Effexor? It's difficult. You know, they get the brain zaps, they call them. And then they get this weird kind of dizziness. It's not harmful at all, but it can be very disconcerting. You can use 37.5 milligrams for a week or two to get them off of it. So this was an issue of Consumer Reports from 2004, and so I scanned the actual issue. I was living in Mount Pleasant at the time. But Consumer Reports asked their readers, have you been treated for depression? And I think a couple thousand said, yeah, they had. And so Consumer Reports asked them, what treatment are you getting and how do you like it? And psychotherapy was preferred by a slight margin, but it was the smallest percentage. But venlafaxine was the antidepressant that people were happiest with. So when you take that piece of information, although it's not a journal as such, and you look at the meta-analysis in the Annals, it kind of gives, I think, a reasonable assumption that there is a slight edge for Effexor. So you guys probably remember the STAR-D trial. Notice that in the STAR-D trial, the maximum dose of Celexa is higher than we're permitted to prescribe today, unless the patient's an ultra-rapid metabolizer at 2C19, which we'll talk about in a minute. But now 40 milligrams is said to be the ceiling because of concerns about corrected QT interval. And the FDA actually said there's no evidence that 60 milligrams is better than 40 milligrams. And I thought, well, what about the STAR-D trial? Didn't that say that that was better, you know? But anyway, with citalopram alone, about 30% went into remission. The other 70 were switched to, either went to augmentation versus switching versus augmentation or switching with cognitive psychotherapy. So adding buspirone versus bupropion, 30% went into remission on that arm. So that's 60% at this point who went into remission. Now this isn't response, this is remission. This is no longer clinically diagnosable as having depression. So the switches went to Effexor XR, bupropion SR, or sertraline, and you can see the remission rates there. And then CBT without an antidepressant, pretty robust, 31% went into remission. Then, if they didn't go into remission at that point, they either got switched to Remeron, nortriptyline augmentation with T3 or lithium, or switched to tranylcypromine, which is a monoamine oxidase inhibitor, or what's called California rocket fuel, which is venlafaxine plus Remeron. You know, you don't see that often, you know. That's maybe the rocket fuel thing. But anyway, so this was the STAR-D trial. And this, you know, I think it's reasonable for primary care providers to go through these two levels. At this point, you want to refer. And I think when this article first came out, a lot of us in psychiatry were going, damn, we're only getting 60% remission rates with antidepressants after, you know, 2 phases. But this doesn't take into account that they were all given citalopram at the beginning. So there was no effort to try to match the antidepressant to the patient. And 60% remission, to me, is not that bad. There was a lot of response that was higher than that. So this is the relationship between venlafaxine and desvenlafaxine or Pristiq. Venlafaxine is a great medication, but some people are fast or slow metabolizers at 2D6. Pristiq takes that out of consideration. So what you can see is that this moiety here is just replaced with a hydroxyl group, and otherwise it's the same. So these are the novel agents: Viibryd, Savella, Fetzima, and Trintellix. Okay, so here's Viibryd. Viibryd is vilazodone, and here you have the chemical structure of vilazodone, and this is the chemical structure of trazodone. So they're pretty similar in terms of their morphology. And this one has a titration curve, and this is one of the medications they call, you might have heard this, has anyone heard of a serotonin modulator? So this is what the company is talking about. So it has serotonin reuptake inhibition, but it's also an agonist at some postsynaptic serotonin receptors. If this is true, if this pans out, then the serotonin modulators might be better agents, slightly better than other antidepressants. I put the pricing on here, and I just realized that's hard to see, even for me, but 40 milligram dose, 30 of them is about $278. So that's not too bad. You know, like Zoloft would be a couple of bucks, you know. But the side effects include things like nausea. The modulators are pretty bad for causing nausea, but if you take it for with food, it's not that bad. Hopefully, I don't know if you can see this in your notes, but hopefully you can read that in your notes, the side effects and the cost. Anyway, this is Savella. Savella is milnacipran. It's an SNRI. Like all the SNRIs, it probably is an effective treatment for chronic pain. And it's only FDA approved for the treatment of fibromyalgia. It's not FDA approved for the treatment of depression, although there's no reason why you couldn't use it for that. If you have a patient with fibromyalgia and depression, I think it would be an elegant medication to prescribe. It has two isomers, like citalopram. You know, citalopram has a levo isomer and a dextro isomer, and it's the levo isomer that is actually the more effective one. And so they have Lexapro, which is just the levo isomer. Well, it's similar with Savella. Savella has both isomers here. And the thing about it is, it's a little more expensive than milnacipran, which is just the levo isomer. So they didn't have, so here the 60 of the 100 milligram ones are $346.42. 25 milligrams, 60 is $418.97. Well, that doesn't make any sense to me, you know, but why they would do that. But anyway, the higher dose is less expensive. Now here's Fetzima, which is the antidepressant, which is the levo isomer, just this one here, milnacipran. And the reason that this is the one you want to prescribe for a depressed patient who does not have fibromyalgia is actually it's a little bit cheaper. Here the 120 milligram 30 is $349.39. None of these break the $400 mark. So now this is Trintellix. These four medications, by the way, I was 22 years in VA. I left VA about 2.5 years ago to go to work at Baylor and Menninger. And, you know, I never heard of these medications. You know, I was like, Fetzima? Isn't that shaving cream? You know? I was like, you know, VA didn't want us to know about this stuff. No. You know, couldn't have any drug reps on the campus or anything, you know. So I get to Menninger and they're using all these novel agents and I'm like, oh gosh, you know, I got to read up on these, you know. So I use a lot of Trintellix. This is its chemical structure. They advertise it on television, and one thing they say on TV that has been consistent with my experience is that it's not terribly bad for causing sexual side effects and weight gain. Like Viibryd, it is a serotonin modulator. In other words, it's an agonist at several other serotonin receptors, and there's a whole bunch of them. Now, the patients tell me, I couldn't find any information on what it costs. The company's probably trying to keep it a secret, you know. But my patients have told me that it costs, you know, as much as $1,000 a month. This is a pain, and I hate to do this, but for patients where I think it would be very helpful. Now, a lot of my patients are very wealthy, Most of them are. And so I'm like, you know, this costs $1,000. Yeah, okay. You know, must be nice, you know. You know. So, I mean, NFL patients are like, I just signed a contract, you know. So, yeah, so like one of the guys that I work with had an oil man as a patient, and he walked the patient out and he went back and the guy had left a $500 tip on the table, you know. I mean, it's like, you know, this is very different from, you know, most of my patients in VA came to VA because they couldn't go anywhere else, you know. Now I've got these guys, you know. But anyway, I have been able to get insurance companies to pre-certify patients for a year of Trintellix therapy if they have failed 2 antidepressants. You know, it's a pain, but if you really feel like you want something that may work, I think it may actually be kind of like Effexor, a little better than other antidepressants. And so this is how that modulation thing works. So you see they've got the reuptake inhibition of serotonin, and then they've got agonists at a number of these other, and antagonists at a number of these other receptors. Now 5-HT3 is the one that is associated with nausea, and so they do complain of nausea because it's an antagonist. Their agonism would actually have less nausea. So I always have to tell patients that they need to take this with food. I felt it necessary to include what's on their website. The clinical relevance of the pharmacological activity is unknown, especially, you know, we have to wait and see if this modulator thing really pans out, and these are, in fact, better antidepressants than others. So Selegiline Transdermal is a nice option if, you know, your patient has had jaw surgery or something. It is a monoamine oxidase inhibitor, but at the lowest dose, you don't have to do the dietary restrictions. When I was in medical school, the dietary restrictions were easy because people didn't really drink a lot of Chianti or have hard cheeses. You know, now everybody does this, you know, so you have to make sure they get appropriate education. And they cheat. They cheat on the dietary restrictions when they take monoamine oxidase inhibitors, and they do okay. But there's 2 foods they can never eat, ever. What do you think they are? Pickled fish, which does not sound delicious, and sauerkraut, because they're both extremely high in tyramine and can cause tyramine crisis. Now, when we choose an antidepressant, we take a number of things into consideration, like drug interactions, side effects, genetics. Like obviously, if you had a patient who had a very asthenic habitus, you wouldn't worry too much about using a medication that might cause a 10-pound weight gain. But if you have one that's struggling with glycemic control, you want to avoid something, if you can, that can cause a weight gain. So side effects, genetics. This is getting to be a very interesting area. What they've taken in the past and what worked, especially in family members too. The cost and the status of the GI tract, you know, for example, if they've just had jaw surgery or something and can't take an oral medication. So this is from University of Indiana Department of Medicine webpage, clinical pharmacology. And this just shows how the cytochrome oxidase system is an important consideration when we're choosing an antidepressant. And some things to highlight. I mentioned that citalopram or Celexa has important drug interactions with some of the proton pump inhibitors. I always have to look it up, but they're the most commonly used ones. So you have to check it because the QT interval prolongation can be a lot more of a problem with some of them. By the way, I went to France and I said, is it torsade de pointe or torsade de pointe? And they said, je sais pas. So even in France, they don't know which one it is. So it's either torsade de pointe or pointe. I think you can pick which one you say. Polymorphic VTAC. Okay, so another important drug interaction is metoprolol and fluoxetine or Prozac. So the citalopram plus proton pump inhibitor, the nifazodone plus HMG-CoA reductase inhibitor, the metoprolol plus fluoxetine. I think those are the 3 most important drug interactions that we would encounter in primary care. So this is the VAST-D trial. It was a VA trial, and this was a study where they looked at switching versus augmentation in patients with major depressive disorder. And so they got a typical antidepressant like an SSRI, and then if they didn't go into remission, remember that's a pretty high bar, remission, they were switched to bupropion. Bupropion was added, or they added Abilify. And there was about 500 people or so in each group. And so the Abilify was the augmentation, and that's the sort of the amber-colored line. And then augmented with bupropion is the black one, and then the switch is the blue one. So basically what this showed is that adding bupropion was a little better than switching to bupropion, and adding Abilify was a little better than adding bupropion. They said that this was a predominantly male population. They had, their first antidepressant was SSRI, SNRI, or mirtazapine, which I think makes it a little better study actually than the STAR-D in that regard. And they said that augmentation with Abilify resulted in a statistically significant but only modestly increased likelihood of remission compared to switching to bupropion monotherapy. I think the important thing here is while it's probably somewhat better, and they raise this issue, there are things about using a second-generation antipsychotic that can be problematic, like weight gain, the metabolic effects, and even possibly movement disorders. Okay, now, have you guys seen these genetic tests? Some of you must have seen them. This is like the next big thing in psychiatry. And when I got to Menninger, all of my patients were getting genetically tested. And I'm like, what is this genetic test? How do you interpret this? So I had to do a crash course interpreting this test. I've seen patients who come to me on the professionals program who have had genetic testing, both the Genesight and the Genesight Genomind test that we use at Menninger. And I've seen patients come from primary care doctors and other general medical doctors who have other kinds of genetic testing done that include trying to identify which would be the best antihypertensive, for example. And so the Genesight test reports it by medication. So you can see over here, this individual had a test that said that suggests using Pristiq, Fetzima, or Viibryd. The yellow, trazodone, Effexor, MSAM patch, which is Selegiline, fluoxetine, says that you can probably use those. It says, significant issues with the other antidepressants. The Genesight, the Genesight or Genomind test, I prefer because it doesn't go by medication at first, it goes by gene. And it gives more recommendations about things that we should consider. The Genesight actually tests for two genes that the Genomind does not, and they have to do with the likelihood of getting Stevens-Johnson syndrome on Lamictal or lamotrigine. So you see on the Genomind test, it'll give you a gene, and then it'll give you some background, and then it'll say, whenever you see that exclamation point, it means an important thing to be cautious about, and then it suggests a treatment with a light bulb. So this is a better look at the way that they do the Genesight. So they have antidepressants, and they go through other kinds of medications. Then it shows you down the metabolic pathways that they go down and make recommendations accordingly. Now again, I like this one better. You can see here that this says, like at the very top, it says, that's SLC6A4. So it's saying this patient is LA at this locus. That means that they're more likely to respond to an SSRI antidepressant. Then you have a couple of genes that warn you about the risk of weight gain on second-generation antipsychotics. And then they even go through, has anyone had a patient on Deplin or L-methylfolate? Anybody seen that? We're using a lot more of that now because there are two enzymes, the MTHFR gene, we have a nickname for it, but the MTHFR gene, pause for laughter. So this gene has two loci that code for enzymes that produce serotonin, and they use folate as a cofactor. And so some people have low activity at those genes. at those enzymes. So what we do is we skip over that bottleneck by giving L-methylfolate. So we're doing a lot more of that. And so wherever you have a check mark, it says no drug-gene interaction. And then it goes down the 6 metabolic pathways, and it tells you, whether this patient is an ultra-rapid metabolizer, an intermediate metabolizer, and so forth. So then you get anywhere you see this dark blue check mark, it's recommending that therapy. So here's the SNRIs. And down here, so it also tells you about whether or not the patient is likely to respond to opioids, which I don't use that much of, and whether opioids should be avoided. And then there's the L-methylfolate, the MTHFR gene. Another gene that's really important it looks at is GRIC1. If a person is of European extraction and they have an alcohol use disorder, they're likely to respond to Topamax as a reduction in their alcohol use. And so the GRIC1 gene is very useful. So there's a lot of useful genes on this. So here's the problem. Rationally, let's be Plato for a second. So we're Plato. Rationally, this is a great idea. We will probably save time picking antidepressants and other medications for patients if we use this test first. Now we're going to get over here and be Aristotle. Aristotle says, here's the study that has not been done. 1,000 patients with depression who get a Genomind test, 1,000 patients who the psychiatrist uses clinical reasoning. How are they after a year? Are these guys better than these guys? That still has to be done. For patients who have insurance and have failed several antidepressants, the Genomind test costs $300. So and patients love it. It's like 23andMe. But they'll ask me, they'll say, hey, if I get this test, can I tell if I have any Polish? Because my grandmother always said we had Polish. No, it won't do that, It's just about picking medications. That's all it does. So I think this is my last slide. Yeah, that's the Turkish Center in Houston. So they have a big Turkish center with an it's an amazing city. Go there, and go to a game, and it's one of the most amazing restaurant cities in the country. We have a Uyghur restaurant there. Anybody know who the Uyghurs are? They live in Western China. They're kind of Turkish, and it's really great food. So anyway, that concludes this talk. Any questions?
A couple of minutes for questions.
Give it the box.
The recent Swedish study on the use of lithium in recurrent depression admissions, and psychiatry letter saying about lithium being one of the premier drugs in treatment of depression. Can you comment on that?
Thank you for asking that question. I love lithium. And here's the thing. Lithium is a better drug for an internist than a psychiatrist, I think, because you need to know about renal physiology. Now, what lithium does that psychiatrists don't always get is it inhibits an enzyme called adenylate cyclase. So cyclic AMP levels drop, and that produces a couple of important clinical effects. One is psoriasis in predisposed patients. Another one is nephrogenic diabetes insipidus. So it's critical that patients who take lithium never get dehydrated, because what happens when lithium patients get dehydrated, they get lithium toxic very quickly, and it can even happen after they stop taking lithium, because as the kidney tries to eject sodium, you may recall that in the emergency room, one of the most common causes of hyponatremia is dehydration. The kidney has been jettisoning sodium, but it will do that by pumping lithium back in. So, so these are important things. Hypothyroidism is also a cyclic AMP-mediated problem from lithium. I think an internist is in a better position to surveillance those things than psychiatrists in general, especially the newer generation of psychiatrists who do very little general medical training. So I do a lot of teaching about this. Lithium is a powerful agent against suicide. And so your depressed patients are at the highest risk of suicide, and lithium, we know, inhibits suicide. And we know there are even studies that show that people who live in areas where the water has more lithium in it have lower suicide rates than people who live in places where the lithium levels in the water are lower. So, and it was discovered by John Cade in Australia back in 1947. It was the first medication actually ever discovered that has a specific psychiatric effect, beneficial effect. The biggest problem with lithium is patient acceptance and tolerance. There are things that they don't like about it. One of them is the tremor. They don't like that. And they don't like the increased appetite. Now, the weight gain that they get from lithium is not, it's really important to understand this, it's not extra fluid. They're drinking a lot more because lithium inhibits adenylate cyclase, which is how the kidney responds to antidiuretic hormone. So the kidney becomes deaf to antidiuretic hormone, and they start jettisoning water, so they have to keep up by drinking. So a lot of people think that they have fluid gain, but that's not the case. They're actually struggling to keep up with the loss of water through the kidney. So for patients who are suicidal, I think it's absolutely essential to consider lithium therapy. The patients could gain weight. There are drug interactions, particularly non-steroidal anti-inflammatory agents, but also ACE inhibitors that can raise lithium levels. But I love it. I had a patient, an attorney from the Pittsburgh area, severely depressed, had him on second-generation antipsychotic plus antidepressant, had him on Effexor because I thought, well, let's pull out all the stops here. Didn't respond, put him on lithium, his mood came right up. So very powerful agent, and I love it. So I believe in it very strongly.
Yes, what about the use of ECT treatments?
Yeah, I didn't mention a couple of things. ECT is one of the most effective treatments in medicine, and it's very safe. And most of the miraculous things I've seen in my practice have been patients who got ECT. Supposedly Hippocrates noticed 2,400 years ago that patients who had malaria and had seizures, the seizures from the high fevers would treat their melancholia. And so that's what seems to work. And what it does is it causes really dramatic increases in brain-derived neurotrophic factor, and that is known to help depression. We don't use it first line. There are no known long-term side effects. Patients do get temporary memory loss. Another one I did not mention is ketamine. So ketamine is an intravenous treatment. It works very quickly. At Menninger, we will give patients a 2-treatment trial. Usually we know within 2 treatments if they're going to respond, but it's a very new treatment. It's a FDA scheduled medication, so it has addiction and abuse potential. And there was another medication like that Freud used that really helped the depression, but it was called cocaine, and it didn't pan out. So ketamine is something we're kind of keeping an eye on. We use it in cases where we've tried things, but they have not worked. And then there's TMS, which is the benefit of TMS is that the patient is conscious during the treatment. You don't have to use general anesthesia.